what John Ward said from the CDC perspective, what Grant has outlined in terms of the national HIV strategy. I have to say, as a disinterested party, I think that the federal government makes a major contribution. So again, we appreciate all the efforts that you made. Not that I have any conflict of interest. So to get another perspective on this, Jen Cates is our next speaker. She's well known as the Vice President and Director of Policy or Director of Global Health and HIV for the Kaiser Family Foundation. She focuses on analysis and research of U.S. government roles in HIV and global health. So we're very pleased to have her perspective on the issues we've discussed.
Good morning, everyone. I think to take a page from Grant about being in D.C. and politics, I also need to invoke something that's been in more, not current, but recent political discourse, Sesame Street, and just say one of these things is not like the other. I'm not a member of the federal government, but I've been asked today to present to you something that you just heard about, the work that the Institute of Medicine did. And I'm very happy to be able to present it as a member, as a committee member of that work. And one of the reasons I think it's important for you to hear about it is that, first of all, I don't think a lot of researchers know that these reports were done. I was talking to an HIV researcher yesterday who works very regularly in the policy field on HIV and didn't know about these. Second, they are actual examples of where, and this doesn't always happen with IOM reports, where the federal government is using the recommendations currently and trying to implement and make change. So we're very happy about that. I'm also, I just need to say that Paul Volberding was supposed to be here doing this. He's the chair of our committee, and I cannot replace Paul, but he wishes he could have been here as well. And Ken was on the committee, and probably a few others are out there, as well as the staff from IOM. So very briefly, I'm not going to go into all the detail. The main point here is to know what the big point messages were from our two reports and let you know where to find them. So the White House Office of National AIDS Policy commissioned the Institute of Medicine to do these two reports. The first one was to focus on what would be core indicators for assessing HIV care in the U.S. and assessing care from the perspective of the strategy and the ACA. So what would be the best set of core measures, as well as data sources and barriers and other things. And the second was, given that, is there a way to obtain a nationally representative study, estimates of people with HIV in care so we could assess their impact? For those of you who've been working in HIV for a long time, you know that that's a big, hard question for all of us. So it was one that we were, I think, really excited to be able to address. I just want to show you the other committee members. I mentioned Paul and Ken, who's here, and is anybody else here? Okay. All right, so I'm going to briefly highlight the main things from each report that I think that would be helpful for you to know about. You can get the reports. I'll have the links at the end. Everything is publicly available and free. So the first I wanted to just mention is we, as a committee, for those of you who have been part of an IOM committee, you really try to take the charge and figure out what's your approach. And a few key things about our approach to the first one was that we wanted to use the actual targets in the national strategy and other indicators that are out there for HIV care. We weren't starting from scratch, obviously. And we used those as our basis. We reviewed public data sources, private data sources, and as everyone's been talking about, we used the cascade. I mean, that was our framework. And so a couple other things we did do is we limited the scope of what we were looking at to the population of people with HIV who were diagnosed and ages 13 and older, so adults and adolescents. The big recommendation, there were many that I wanted to focus on, is the first one, which is we recommended that HHS should use the following core indicators to assess the impact of the strategy and the ACA. And we identified 14 core indicators, 9 for clinical care, and I'm very happy to say that the committee, and we felt strongly about this, 5 for mental health, substance use, and supportive services. And we also identified many others that we felt were important but weren't necessarily of that core set. This is a very complex slide, but it shows you the continuum and all of the indicators along the continuum. And as you heard, what was exciting to us as we were doing this process is we understood that HHS had begun to explore a similar thing, what would be core indicators for the federal government, and the set that's been adopted is a subset of these indicators. These were the other recommendations of that first report. A few things to highlight. They're in red, that we recommended that the government be expanding the demographic data that are collected to collect things that many of us think are important to understand about the population of people living with HIV, including gender identity, sexual orientation, income, poverty level information. We also wanted to make sure that the process for looking at these data systems was an ongoing one. That's recommendation 3. 4, for those of you who worked with the National HIV Surveillance System, we felt that that system really could be enhanced and used for a lot more than it is being used for. We also looked at the potential for private data systems to be used. That's 5. 6 was around streamlining reporting requirements. And again, as you heard, that's another area where HHS is really working to do that. We showed in our report, as all of you have probably seen, the famous NASDAQ diagram that shows all the federal reporting requirements that everyone, their eyes go like this, and now the federal government is actually trying to condense that set of requirements. A big question that came up for the committee, and we know is one for probably a lot of you, is what is permissible in terms of information sharing given state privacy laws, given federal privacy laws? If we know that we have to know what's happening with patients across a continuum, how can we best do that given restrictions, given privacy concerns? Obviously, a lot more recommendations. I just want to highlight the last one here was we recommended that HHS should report to the public at least every 2 years on these indicators and what is happening with these indicators. So that was the first report in a very quick minute. The second report was the one about nationally representative estimates of people living with HIV, so we could monitor current care and look at the impact of the ACA over time. And what we chose to do in terms of our approach was to understand the pathways at which individuals currently get access to care and what might change with the implementation of the ACA. And we linked this report to the first one in many ways. I'm not going to go through this, but because we were looking at what the impact of the ACA was, we identified, and we have a chapter on this, all of the different ways in which we saw the ACA changing the pathways to coverage for people with HIV. And the report has diagrams in it that we developed at Kaiser that look at how those pathways might change. So a quick, easy way to sort of see what it looks like pre-ACA, currently, and then post-ACA. One of the things I'll highlight here in this diagram is you see all the way to the right, Ryan-White continues to be critical throughout, even after full implementation of the ACA. The main finding I want to highlight from this second report was that there was no single source of data to generate a nationally representative baseline of people with HIV prior to the ACA. That's probably not a huge surprise, but that was what we came to. But we felt that there was a lot that could be done with existing data sources, and we also identified one data source that we felt could be enhanced by the federal government and used as a basis for developing a representative sample, and that's the Medical Monitoring Project, a project of the CDC. So here are those recommendations, and just to highlight that first one there, that in the meantime, because there's no single source, ONAP should use multiple sources to try to establish a baseline. And if anyone is interested in what those are, they're in detail in the report. But second, that CDC should work to improve the medical monitoring project, because we do believe it can serve as the basis for obtaining a nationally representative data set for people with HIV going forward, supplemented by other things. And we looked at something like 30 different data sets, and we assessed each one of them for what their representativeness, their strengths, their limitations, what data they collected, and ultimately this is where we fell in terms of what we felt was the potential here. And you know, the potential to not necessarily creating something that would cost a lot more money to create and also a lot of burden. And then recommendation 5, just to highlight this point, that even after the MMP is improved, assuming it is, there's still going to be a need to use data from a whole range of other sources to really understand what's going on for care of people with HIV. So that's a very quick walkthrough of 2 very complicated reports. They're both online. The study director from the IOM and the head analyst are back there in the way back trying to hide, but they're here, Carol Spicer and Morgan Ford, and hopefully we can answer questions if you have them. Thanks.